us. As you know, this is our fourth COVID-related weekly webinar, but this is a very special one as we are joined by a team of experts from Mayo Clinic in Jacksonville. The title of the talk or the webinar is Management of the Failing Heart in the COVID Era. So I would like to take this opportunity and on behalf of the Baptist Hospital Heart and Vascular Institute to thank our guests for their time and for sharing their experience and expertise in these difficult times. We greatly appreciate this opportunity and certainly value our collaboration and look forward to future talks and events. Basically, we have a great panel today. Our guest speakers are, and I hope I'm correct regarding pronunciation, Dr. Goswami, Dr. Leoni, Dr. Siriapulo, Dr. Landolfo, Dr. Pham, and Dr. Patel. In the interest of time, I left out the titles of our guest speakers as these titles will be noted on the slides for everyone. And as usual, if you have any questions or comments, please feel free to type it, and then we'll address them at the end, and we should have enough time to address those questions and comments. And with that, we'll get started. Dr. Goswami?
Yes.
Yeah. Okay, perfect. Sorry about that. I don't know what Zoom was doing. All right, so my name is Rohan Goswami. I'm one of the senior associate consultants here at Mayo Clinic, a part of the heart transplant team. This is our overview. So we're going to be talking quite a bit about COVID and how it relates to cardiac dysfunction, how it affected our practice, and how we've recovered since then. So just kind of a big overview here, looking at the spectrum of pump failure in COVID-19. We look at multiple factors that result in the acute cardiac injury, leading to cardiogenic shock, and then subsequently leading to cardiometabolic shock. And when we also think about shock in the heart failure patients during COVID, we think about how our patients who are waiting on the list as an outpatient or inpatient are affected by COVID, and then also post-surge, how we escalate our practice and resume normal activity. And so we're going to start with Dr. Leoni. He's going to be taking over here and talking about myocarditis now.
All right, can you hear me now?
Yes.
Yes,
Okay.
we can.
Perfect. So, so yeah, we have plenty to cover. So I'm gonna touch somewhat on myocarditis and clinical presentation from a cardiac perspective on these patients. So we're all aware that this has become a global pandemic starting in the US by beginning of January. And at this point, we have about 50,000 deaths in the US. So there's more to come. And you know, from the clinical perspective, we have seen, in addition to the systemic and respiratory complications that we all know, that there has been some manifestations of acute cardiovascular syndrome, and the presentation can be from 3% to 25% quoted in different papers. And the way this presentation has been quoted or coined, I guess it's acute COVID-19 cardiovascular syndrome, or ACOV-CS. And the cardiac complications can occur at any point during the hospitalization. I think that most patients will present initially with respiratory symptoms, and then the cardiac complications show up. But many patients are presented initially with cardiac symptoms. So there have been described 5 phenotypes, and I'm going to mention some of the most common ones. The one that many of these patients have been, or we have been fearing the most, are those patients presenting with chest pain. And one of the common scenarios is that all these patients present with elevation in troponins. And speaking to Brian Shapiro, who is our program director for the cardiovascular fellowship here at Mayo, who is currently deployed in New York, about 50% of the patients in the ICU have elevated troponins with different kinds of phenotypes in terms of their cardiovascular presentation. So some of them will present again with chest pain, increased troponin, diffuse systemic elevations. And these patients have been taken to the cath lab in the beginning of the pandemic, and the coronaries were clean. So that's one of the presentations we have been seeing, and many organizations have been working in how to address these patients. Should we cath them or not, in order to protect their staff and also to protect their PPEs. And some of the venues that some institutions have been using, including Mayo, has been doing coronary CTs to rule out those patients who didn't have any other features except for that presentation. Other patients who had prior cardiovascular disease, especially those with heart failure with reduced ejection fraction, have presented with the compensation of their acute, of their chronic condition. Some have come with any sorts of electrical instability, either supra or ventricular arrhythmias, in way of bradycardia, ventricular arrhythmias, and even torsades. And finally, the one that we as an institution tend to manage as a group is the hemodynamic instability and cardiogenic shock, which we'll speak in more detail later on. But the recurring issues that many of these patients have presented with no coronary artery occlusions on the angiogram. Next slide, please. So again, multiple phenotypes, which makes this very, very interesting. If you see on the diagram on the left, they have the acute coronary syndrome, which we don't know if this inflammatory milieu or maybe this is stabilizing the plaques that some patients might have and causing ACS. But although this is the one that we fear the most, actually is the one that we have seen the least. I think the rest of the phenotypes, including the second to the left, acute myocardial injury without obstructive CAD, is the one that we have been seeing in the literature. And many mechanisms involve either cytokine dysregulation. Some patients are presented with myocarditis and even some form of stress cardiomyopathy. Interestingly, I was reviewing a paper from one of our fellows from Spain that rotated with us a couple of years ago, and had a presentation of a patient that came with SCAD, with spontaneous coronary artery dissection, and that particular case is going to be was submitted and accepted in the European Journal of Cardiology. Again, other presentations, arrhythmias of any sorts, supra ventricular arrhythmias and ventricular arrhythmias, heart failure with cardiogenic shock. Some of these patients have been presented with pericardial effusions and tamponade. And then you have heard about thromboembolic complications. A recent paper was quoting patients in the ICU with 25% of them had some sort of thromboembolic complication. Next slide. So the common feature on these patients has been really the abnormal troponin. And different mechanisms have been really related to why these patients are more susceptible to have the cardiovascular complications of COVID, either from pre-existing cardiovascular disease. I'm sure that many of your patients have requested you to have letters to take them away from work, or we had that especially in the beginning of the pandemic, where they asked us for a letter for 2 weeks to be at home, and now we don't know how long this is going to be. But many mechanisms relate to hypoxemia, which definitely it's out of proportion to the findings that we see on the CAT scans. Again, ventricular arrhythmias, we spoke about that, hypotension, shock. Again, viral myocarditis, cardiac MRIs, even biopsies showing inclusion of these viral particles in the electronic microscopy. And you have heard about cytokine storm. Next slide. So finally, again, this is not your usual myocarditis. This is not the typical Coxsackie type myocarditis where there's a molecular mimicry of an autoimmune response to the cardiac tissue. This is more viral entry of the COVID-19 into the myocardial cells and direct cytopathic injury. And compared to the usual myocarditis with lymphocytic infiltrate, this actually we have been seeing macrophage infiltrates with different receptors being activated. So the inflammation primarily is mediated by macrophages, not by lymphocytes. And one of the theories that we have been seeing is that this exaggerated cytokine release or cytokine storm. So also the other mechanisms have been the potentiation of the TGF-beta, and which is related to aortic aneurysms and dissection. We have actually, I couldn't find any particular case about COVID-19 related aortic dissections, but one of the interesting things is that many of the patients that have received a cardiac MR have had interstitial fibrosis. So you wonder if we're not gonna see patients at this point that recover with heart failure, but maybe in the future we'll start seeing some of these patients coming with having had a history of COVID-19, having recovered, and now having interstitial fibrosis. Next slide. So, and this is a patient that was reported in Brescia, Italy. And you can see on those pictures with electronic microscopy, you see that the particle of coronavirus inside the cytoplasm of cardiomyocytes. So again, different presentations compared to the usual myocarditis. Next slide. So finally, you know, you see different molecular structures that are involved in this process. You have heard about the S protein on the surface of the viral particle that attaches to the ACE2 molecule on the surface of the, in this case of the cardiomyocyte. Again, this ACE2 molecule can be present in many other tissues, especially we have heard about the lung one, but also it's in many other tissues, including the heart. And there's also another molecule of adhesions called TMPRSS2. So the importance of this slide is mentioning that there's some therapeutic targets that they have been looking into, either antibodies against the S spike protein, or the antibodies against the ACE2 attachment, or even the TMPRSS2. So we'll see, we'll have more to see, but this is just a brief introduction about the clinical presentation, including myocarditis of patients with COVID-19.
Thank you, Juan. Now we're going to move on to some clinical feature that all of us obviously are worried about most in these patients, and that's cardiogenic shock. And so, as Juan had mentioned earlier, it's really important to note that the presentation for cardiogenic shock or even cardiac syndrome is actually typically, while it can happen at any point, it's typically later in presentation. So here's some data that actually came out of Wuhan, looking at basically when patients develop sepsis, ARDS, and cardiac injury. And typically patients will come in with fevers and cough, but when specifically looking at the second part of this graph, when you can see that in the non-survivors, patients typically presented with sepsis, ARDS on day 11 or 10 and 12, and then ultimately developed acute cardiac injury on day 15. Again, most of these patients aren't coming in with frank shock. In fact, it's interesting to note that many times patients are actually improving from a respiratory standpoint, sometimes even extubated, and then they develop a cardiac issue. So just because you can extubate somebody doesn't necessarily mean you're out of the woods. Next slide. So when specifically looking at kind of the types of shock and the types of causes of hemodynamic compromise, the data suggests that a majority of them are going to be respiratory related. So again, this is a separately published paper in Wuhan looking at over 150 patients of which 68 died. And when you look at them, other people who died, 53% primarily had respiratory failure, 33% had respiratory and heart failure, and only a small amount just had isolated myocardial damage. So the etiologies of shock include respiratory failure, myocardial dysfunction, secondary bacterial infection, cytokine storm, which we'll get into in a minute, and then of course metabolic disarray. So when you have somebody with shock, obviously the first thing is to complete a thorough workup to identify what is actually causing the shock. So in addition to our standard workup to look for end organ damage, including lactate, LFTs, beyond creatinine, electrolytes, and LFTs, we want to kind of identify what type of, what the primary insult is that's causing the shock. So we would undergo a respiratory evaluation, checking ABGs and a portable X-ray. Obviously, we try to avoid CT scans given the risk of exposure to other people, and also the fact that these patients are relatively unstable. And so if you can get away with identification of etiology with imaging that can be completed in the room, that's always preferred. Specifically with regards to infectious workup, it's important to note that 16 to 20% of non-survivors actually have secondary bacterial infection. So if a patient has respiratory failure and they start declining, don't forget about the potential infectious etiology. So check a CBC with lymph. Remember that 83% of them are lymphopenic. However, when specifically looking at the patients who develop secondary bacterial infection, most of those patients actually had an increase in their white count over time. Do blood cultures. The utilization of sputum by bronchoscopy is a debate. Obviously, again, we want to minimize exposure and risk to healthcare workers while appropriately managing patients, and so that's going to have to be a clinical decision based on the patient. Make sure you get a UA in cultures and check out procalcitonin. Next slides. When looking at cardiac evaluation, as you guys already know, it's important to do troponin, BNP, EKGs, point of care ultrasounds. And I think when somebody's crashing, it's important to try to assess hemodynamics in the most minimally invasive way possible. And so we'll get into the next slide, but I do think a poor man's swan, which is basically a central line or a PICC line, is a very good way to look at hemodynamics and help you differentiate the type of shock. And then in the really, really complicated cases where you need to kind of where you have cardiogenic shock and you need to distinguish between right versus left-sided shock, et cetera, then a PA catheter may be of use. And I'll talk about that in the next slide. But it's important to note that of hospitalized patients, about 20 to 30% of patients will have some form of cardiac involvement, whether it's cardiogenic shock or CHF. If you do have cardiac involvement, it is associated with a very poor prognosis. 52% of non-survivors in a small series had heart failure or cardiogenic shock versus only 12% of the survivors. And, you know, when you look at the Washington State experience, about 30% of patients admitted into the ICU actually had heart failure or cardiogenic shock. So it's not a small amount of patients, and understand that it's associated with poor outcomes. When looking at kind of invasive assessment for shock, again, the poor man's swan is a reasonable option. If you have a central line or a PICC line, and if you have a valved PICC line, make sure you use an adapter. You can get very important hemodynamic measurements. You can get a CVP, you can get a SVO2 or venous blood gas, and through that, you should be able to estimate fit cardiac output and systemic vascular resistance. And so if you have right atrial pressure, estimated output and systemic vascular resistance, you should be able to best differentiate your type of shock. And so remember, in these patients that there are several different factors that can affect SVO2 that include oxygen delivery to the lungs, hemoglobin carrying capacity, oxygen delivery and uptake to the tissue as well. And so if you have somebody that has a decline in their SVO2, remember that lungs can actually affect it, hemoglobin can affect it. So only use SVO2 as a surrogate for cardiac output if your oxygenation and your hemoglobin and your consumption is relatively unchanged. Next slide. Now, when you're undergoing your evaluation for shock, it's also important to see whether there's cytokine activation. You should check for coags, fibrinogen, and D-dimer. Some centers will also talk about checking ferritin, LFTs, CRP, and IL-6. And the reason why you want to do this is because you may actually adjust your therapies based on the results of this. So here's data from 2 different centers, and both centers actually show they're stratifying some of these biomarkers based on patients who survive and not survive. And you can see that there's a marked increase in D-dimer, a drop in lymphocytic count, increase in IL-6, ferritin, high sensitivity troponin, as well as LDH in the non-survivors. And so, and there's been an association of increased CRP in non-survivors versus survivors. So there definitely is some form of cytokine activation in the most sick patients, and these are the patients that may need kind of out-of-the-box therapies that haven't been quite yet proven, and I'll get into that in a second, at least for consideration. So in terms of undifferentiated management, give your antibiotics, start your pressors, norepi and epi initially, and then once you find the etiology of the shock, then adjust your pressors accordingly. Remember, it's important to note conservative fluid management. When we talked to the people at NYU, this was a very important thing that was highlighted by their team, is conservative fluid management. Don't give conventional 30 cc's per kilogram resuscitation, because most of these patients have ARDS. And so based on the WHO COVID-19 guidance, really the idea is to avoid IV fluids if needed. You can start off gently with 250 to 500 of IV fluids, assess for responsiveness, and then go forward. And again, in terms of the really sick patients, you can consider stress dose steroids if somebody's on pressors, and I'll get into steroids across the board here in a second. So next slide. So when you're talking about shock management in general, you manage them as typically as our standard non-COVID patients. So if a patient has high CVP or wedge, definitely give diuretics. If somebody's SVO2 is low, consider giving them inotropes. Make sure the negative inotropes are held, the beta blockers and the calcium channel blockers. And I've included your hemodynamic goals over there. And the one thing, two things I want to note is you can see most of those hemodynamic goals can be assessed with just a central line. And so if you have a central line that you can connect to a CVP and an SVO2, like I said before, you should be able to minimize the risk to your team in terms of not necessarily needing a PA catheter. And also keep in mind, early consideration of mechanical support is key. I think one thing is, in order to, again, protect the patient best and to minimize risk to our healthcare workers, what you don't want to do is have somebody crashing and then you deciding to utilize mechanical circulatory support. You want to watch their hemodynamic parameters, your cardiometabolic parameters early, and before they delve into cardiometabolic shock, you want to kind of make the decision of temporary mechanical circulatory support before they get to the point where minutes are key. In terms of cytokine syndrome management, it's important to note that there are a lot of compelling case reports, but no robust randomized data. And so several different options have been discussed, including IVIG. Steroids, depending on the data that's come out, which is small, some suggest steroids are associated with adverse outcomes. Some are say it's associated with appropriate outcomes. Consider IL-6 blockers, hydroxychloroquine, antivirals, and again, convalescent plasma has shown some interesting interesting results in a small cohort of patients. And this is more of a joke, but ingestion of disinfectants probably is not a good idea for these patients. Last slide here. Remember this much, is that cardiac arrest in these patients is associated with very poor outcome. So again, this is data in Wuhan. In hospital cardiac arrest in 136 patients, 118 did not achieve ROSC. And of those who achieved ROS, 14 died and 14 survived at 30 days. The initial rhythm was asystole, which is kind of interesting. That's kind of your rhythm that you would see in people with infiltrative type cardiomyopathies that fail, that die or have pump failure. It's uncommon or less common that you'll see PEA or VT, but important to note that when you actually look at factors associated with ROSC, and location of arrest was key, so ICU patients did better than ward, but initial rhythm is also very important. So those who had VT actually had a better survival than those who had PEA or asystole as their inciting rhythm. So just keep in mind that if you needed to do manage somebody with cardiac arrest, outcomes are quite poor in that group. Thank you, and now I'll give it to Dr. Pham, who's going to be talking about ECMO support and temporary mechanical circulatory support.
And I have a little pause here.
Rohan.
We're going to just switch sharing the screens. Dr. Pham has some pretty cool videos that he wants to show you guys.
Okay.
Dr. Pham, if you want to go ahead and share the video.
Okay. So can I share mine now?
You should be able to, yep.
Okay. Can you see my slide yet?
It's starting to load.
You see it?
Yeah, we can
Perfect.
see it.
Yeah, if you just maximize it.
Okay. Okay. So my portion of this talk is to talk about the use of ECMO to support the failing heart in the in general, and then on the COVID patient. And as mentioned earlier, the cardiac injury usually is a late complication. It can happen after the respiratory failure has recovered, and the whole spectrum you heard earlier is it can include cardiomyopathy, atrial arrhythmia, or MI or heart failure. And the treatment for cardiogenic shock in general and in this patient population includes the temporary assist device. And this slide show you a whole spectrums of temporary percutaneous device that can be used. And we talk about from the Impella to the ECMO to other devices. I don't think the balloon pump is appropriate. It's not adequate in this. So my portion today, my talk today is in this VA ECMO area. Just give you summaries of the principle of ECMO. ECMO is you drain the venous blood, the oxygenated blood, and then you pump into an oxygenator. And this oxygenator, the two function is remove the CO2, CO2 removal here, and then it also oxygenated the blood through the diffusion of the O2 into the blood, and you get oxygenated blood, and you pump it back to either into a venous system for a VV ECMO, or go into the arterial system for VA ECMO. And for the COVID patient, venous ECMO, because of the predominant failure is respiratory, so venous ECMO has been used predominantly in this population. And again, the schematic presentation is you have you take the blood from the venous side and then oxygenate it and bring it into the venous, in this case like the internal jugular veins. For the VA ECMO, here you drain the blood from the cava, you put it into either the femoral artery or into the axillary artery or directly to the aorta. Here is the example, the real life picture. The head is up here and the right groin here and the left groin. So this patient have the venous cannula here. It's a 25 French draining from the right atrium and then get into the left common femoral artery. You notice here we also put another cannula integrate for the perfusion of the leg, and this is very important because in the early days of peripheral venous arterial ECMO, leg ischemia is a real problem. And nowadays we routinely inserted this cannula, so we didn't have much of a problem. Now in this case, you notice the patient also had an intra-aortic balloon pump. He had a balloon pump, and then that failed. That's why we converted into VA ECMO, but we left the balloon pump in because the balloon pump helped unloading the left ventricle. And I will go in a bit more detail on what the disadvantage of ECMO. So it requires a balloon pump to help unload the ventricle and allow the heart to eject so that you don't have stasis in the left ventricle. Now, there's some advantage of the ECMO, and they are listed here, especially in the era of COVID. We don't want to travel to the OR, to everywhere else to get other support device. So the ECMO, it can be done at bedside, and the patient, some of those patients can be activated if the lung function is the lung is working well. They can be out of bed, and some of them, even with the scanulation configuration, they can walk. The disadvantage of the VA ECMO is that the left ventricle is not unloaded, it's not decompressed. And then the leg ischemia I mentioned before. And then you have this phenomenon where you have upper body hypoxemia. This is what we call the Harlequin syndrome. This can happen if you have a combination of VA ECMO with femoral cannulation and poor lung function. So what happened here is that the oxygenated blood from the ECMO go into the femoral, and then they get up to about this much here in the aorta, a bit or even a bit higher. But the heart is still working well, so it ejected the oxygenated blood because the lung is not working well. So essentially you have coronary artery, have hypoxemia in the coronary artery and then to the brain, and this is not a good situation. We have to recognize it early on, and for VA ECMO, especially this kind of scenario, we put the sometimes we use the transcranial saturation thing, but we put the pulse ox in the ear or in the head so that we will monitor that oxygenation better. Now, if we couldn't, if that happened, what we would do, we convert it to what we call a VA ECMO. So essentially, you get the blood, the venous blood out, and then you oxygenate it, and then you send it to the artery system. But some of them you also go into the venous system here. So this case, it go into the right internal jugular vein, and then it can pump into the lung, oxygenated blood, and then it circulates in the upper part of the body. Now, the indication for ECMO in general, and also on the COVID patient, is for VV ECMO is hypoxemia with the PF ratio, the FiO2 PaO2 to FiO2 less than 100. On the COVID patient, it is recommended that you move more quickly because they can decompensate it very quickly. They can sit down, talk. I mean, can talk and breathe, but then the next couple hours they can become severely hypoxemic, and that's why people think that it should, any signs of distress, you should either intubate it and try to move on to a more advanced treatment. For the VA ECMO, the typical cardiogenic shock kind of scenario that you couldn't manage with the high inotropes anymore, and they become acidotic and things. So those are the indication. Now for the ECMO, at least most centers don't place patient on ECMO if they are older patient above 70 years old, and some even consider 65 years old is older. And they have some of the other contraindication, including terminal malignancy, multi-system organ failure. For VV ECMO, if they are on a ventilator more than 7 days, they tend to not recover very well. So those are the patients that we won't use. Some of the things that I need to consider is the certainly the aortic regurgitation because of the left ventricle is not unloaded, so we won't use ECMO for those patients. And patients on prolonged CPR without adequate perfusion, they usually don't do very well, so we don't use them. Now, for the survival on VA ECMO, this is for all comer for cardiogenic shock. This group from Germany reviews 3,000 patients on VA ECMO, and they show a 42% survival, and this is for all comer. And some of the risk factors associated with mortality included in this slide here: chronic renal failure, prolonged ventilation prior to ECMO, pre-ECMO organ failures. The pre-ECMO cardiac arrest is a high risk factor. And then some other thing is showed out there, including the low serum bicarb. Now, for fulminant myocarditis, the survival is much better. This group here published data that recently, and they reviewed 88 patients with fulminant myocarditis, and survival is quite good here. I mean, it's not best, but it's much better than other kind of indication. And the risk factors for mortality is the high CPK level, and if they have any VTAC, fibro asystole before this the ECMO initiation, they have a quite high mortality. Interestingly, the IVIG is beneficial because it improves 60% survival improvement on that. Now, the global experience on the use of ECMO is 2.6% of all COVID patients, and of these 2.6%, only 5% of those patients require VA ECMO. And the number of ECMO as shown here, about of all the patients in the world, 553 are ECMO, and not surprisingly, North America have a higher number of ECMO because certainly we are more equipped to do that. And of these 530 patients, so far 203 has completed ECMO, and of these 203 patients that completed ECMO, the survival is about 41%. And as I mentioned before, because the COVID usually is the lung disease, so 92% are VV ECMO, and only 2% are VA ECMO, and 3% are combination. In conclusion, ECMO can be used for COVID-19 patients with respiratory and cardiac failure. Now, the NIH recommended, because we don't know much about the outcome of these ECMO on COVID patients, they recommended you either enter to a clinical trials or to a clinical registry. And here are some of the websites that show the recommendation from the NIH and also from the ELSO. Okay, so that concluded my part of the presentation. Now, Dr. Seri Upulu is supposed to do this part here, but he's not here yet because he's still in the OR. So I'll go ahead and just start it for him. For the other temporary device that we can use for COVID patient with cardiogenic shock, are the Impella. And we'll focus today more on this Impella CP and the 5.0 here. The right ventricular support, you know, if they need right ventricular support, they usually have left ventricular failure, so we use VA ECMO mainly for those patients. And as you already know, the Impella is a device, a high-speed axial device that have an inflow port right here that going through the motor here, and it have the outflow and bring the blood into the aorta through the aortic valve here. And then the Impella RP is for right ventricular support. Essentially, it's an upside down Impella where the inflow is over here and then the outflow is in the pulmonary artery. So how invasive, and this slide shows the spectrum of invasiveness here. The Impella tandem heart and ECMO and can be done under fluoroscopy, either in the OR or the cath lab. The other device require an operation. Some of the contact indications for Impella LVAD including if they have an LV clot, if they have mechanical aortic valves, if they have aortic stenosis. This is one of the patients that was done using the Impella 4.0. I mean Impella CP, and there's an aortic valve calcification, but they didn't know how stenotic it was, so they tried to push this impeller in, and they couldn't get it in. You know, every time they push it, you have a king here, so eventually you have to be aborted, and we put them on ECMO. But that is just an example of why aortic stenosis is a contraindication, and certainly aortic insufficiency, because the cannula go to the aortic valve, and you don't want the blood to go back into the heart. And so, and some of the patients have peripheral vascular disease and cannot use it. Now, the Impella CP is a very useful device in the first line of defense if the patient in the cath lab and have cardiogenic shock. They are very helpful in at least temporizing the patient until we escalate it to higher form of treatment. But beware of some of the issue with the CP. You can have limb ischemia, and I see we found this technique is quite useful. You know, they have the impeller on this side, and then you put, if they have leg ischemia, you put an antegrade catheter here, and you put a femoral arterial catheter on the contralateral side, and then you connect it to a male-to-male adapter, and that will be enough. The blood will flow from here and go into the leg here and just help with the ischemia of the leg, and that's a very useful technique for our college in the cath lab. As mentioned, it's not adequate support for severe cardiogenic shock. They tend to have hemolysis, and they not it's not a long term, and they have some problem because you put in the groin, you have to keep them immobilized. So our practice is that we temporize them with the CP and then escalate them to 5.0 or 5.5 or VA ECMO. Here is the global experience of Impella use in COVID patient. There's about 124 patients that on Impella, and right now we still do not know the outcome yet, and there are some community support, some still on support, so we don't have the data on that as of April 16 this year. And as this slide shows the trend on the use of ECMO in the on the COVID-19 patient, only about 3% of patients require ECMO veno-venous or veno-arterial. And this is one of the problem with the ECMO is that, as I mentioned earlier, it doesn't decompress the left ventricle very well, and this you can see the stagnant blood flow here in the atrium and then in the ventricle, and you can have clot in that problem. The lung, because you take all the blood out from the lung, you may have some clot in that, and so we try to have some blood flow to the lung to prevent that problem. You need to anticoagulate the patient. But the biggest problem is if you have a severe heart failure, you not adequately decompress the left ventricle. And if that happens, we can use the impeller to decompress the left ventricle. And this slide from a group in Cleveland showing that decompress of the patient with the impeller plus ECMO survive better than the one just ECMO alone, and this is including the short-term 30-day survival and long-term survival at 1 year. And the impeller can be also used to escalate the treatment. You know, typical patient, not the COVID patient here is not a COVID patient, but it can be the same thing. The patient come in, have severe respiratory failure and require VV ECMO to support it. but then initially support with a 2 venous cannula, one in the left groin and one other groin that allow the blood going to the right atrium here. So VV ECMO, and her heart started to fail. So instead of going to the OR, they elected to put an Impella CP in the cath lab. And it's non-invasive, so it's okay, but she didn't tolerate that. So what they did was to leave that Impella in, reduce the flow, but convert it into a VA ECMO, a VAV ECMO. So you're getting the blood return from here, drain the blood from here, and then you getting some blood into the axillary artery here and some into the right atrium to this cannula. So the combination of VAVV ECMO and getting the patient supporting. And when she get better, we win one at a time, initially with this arterial cannula out, and then the Impella, and then the VV ECMO. So this is an example of a patient who is on an Impella 5.0 and able to walk, and his cardiac function improves as the support as time go by. So he's able to go home with a normal ventricular function. So in summary, we have quite a few devices that we can use for these patients with cardiogenic shock. If the right ventricular failure is the only one, then we can use either VA ECMO or Impella RP, or nowadays the Protect Duo with a tandem heart is a good one to use. Left ventricular failure, we can use Impella, we can use Centrimac, or even VA ECMO. Biventricular failure, certainly the trend is that ECMO plus the Impella or Impella. All right, thank you very much, and we finish with my portions here. Hey, Rohan, are you up there now?
Yeah, so now we're going to switch forward here a little bit and talk about transplantation in patients. Sorry, the slide set reset here on me.
Okay, can I stop my or what?
Mm-hmm.
Okay, yeah, all right. Okay.
So we're going to talk about transplant in the era of COVID-19. So, you know, being an advanced therapy center, we have patients that are both high risk for exposure to COVID, as well as patients who have been transplanted or are on the waiting list. And so when we look at the burden of heart failure prior to the COVID epidemic, there's 26 million patients affected worldwide by heart failure, with a projected 8 million in America alone by 2030. And for those patients waiting on the transplant list, the most recent data from January of this year shows that about 113,000 men, women, and children are waiting for organs, and 20 people pass away on average a day waiting for a heart. And so when we think about, you know, COVID and how it's affected the way we practice medicine, and the concern about, you know, we don't know what this virus does and how it infiltrates the heart, and if a patient's positive for COVID, you've all seen these headlines of, you know, is organ transplantation considered essential? Transplantation has been plummeting, has been reported just 5 days ago, and multiple patients that aren't able to get organs because of the concern about coronavirus. And not only just the organ itself, but exposing patients and staff to potential positive patients. And so when we look at organ allocation and availability, we talk about pre and post transplant patients in the COVID era. And so looking at advanced heart failure patients, we kind of see this increased risk of contracting COVID-19, as we've discussed, from direct myocardial inflammation and multiple healthcare contacts, you know, patients coming to the hospital for multiple visits, for lab draws, for weekly evaluations if they're on IV inotropes or if they have an LVAD. And then also the comorbid conditions that they may have: diabetes, hypertension, hypothyroidism, chronic kidney disease. And then we've all heard about this concern for patients with renin-angiotensin aldosterone system blockade with ACE inhibitors and ARBs. And, you know, consensus statements being released by the American Heart Association as far as a lack of information on, you know, do we withdraw this drug from a patient who needs it in order to prevent them from contracting COVID? And so all these kind of questions come into play for patients that we manage. And so when we look at post-transplant patients, you know, we also have to kind of see how they align up with patients with advanced heart failure. And we look at induction or maintenance immune therapy and wiping out their immune system during the time of transplant and the risk of contracting COVID or other infectious conditions immediately post-transplantation. Now, what's interesting is our post-transplant patients also have, you know, multiple healthcare contacts, which increases their risk. They also are going to have limited symptoms on presentation. They're not going to really mount an immune response or have a significant fever. Some of their respiratory symptoms may be complicated by post-transplant immunotherapy and side effects from those medications. I really don't know the data behind that at this point in multiple patients. And then looking at their underlying medical conditions, you've given them a new organ and their heart is, you know, hopefully functioning well, but they've still got their chronic conditions, their diabetes and thyroid and CKD. And some patients may have prior history of cancer therapy, which may alter their immune system overall as well. And so one of the things that we look at with all of these considerations in the back of our mind is how do we select donors, and are donors still being offered to our patients on the waiting list? Now, the interesting thing is initially testing was sparse among our donor organizations who were offering organs to us from different hospitals. But now, since the months have gone by that we've been dealing with this pandemic, the availability of testing is usually within the first 24 hours. What's really interesting to me is the second bullet here is that the sensitivity of the testing is really unclear. Initially, it was reported to be between 59 and 95% as a negative predictive value. So if you had the COVID-19 swab done and you were negative, the thought was that you truly were negative. But we're not 100% sure that that's correct. And the reason for that is if you look at this FDA source, if you're curious, the initial sampling for COVID-19 RNA PCR was actually not done on COVID-19 samples. It was done on surrogates to see if protein content was equal. And so they really didn't test true COVID sensitivity. And then the other thing we look for is if we do get a negative PCR in the donor, is the cause of death in the donor offer in somebody, let's say, who dies of chest wall trauma and has poor oxygenation, and we have a negative COVID test, how confident are we that that negative test is truly indicative of abnormal lung function from another etiology? And how much of a risk are we going to provide to our recipients? And so from the 2 patients who were transplanted in China during the beginning of the epidemic with SARS-CoV-2 and 4 from the SARS-CoV-1 virus, they actually found that those donors were not offered and accepted, and during autopsy that the RNA and the viral protein was not present in the organ at autopsy. Now that is a little bit confusing because we know that the virus does infiltrate the cytoplasm and does infiltrate the myocardium. And so is it the time that the virus had to degrade prior to the autopsy being performed? Was there immunotherapy given when the patient was crashing that caused this to change? We're not really 100% sure. And so with limited data, you know, we're very cautious on the offers that we're receiving and accepting. And so what has that done for us? You know, we're cautious, but we're also mindful of what the patient's needs are and the risks that we take for the donor and the recipient, and as well as our staff. And so during this time, from January to present, we've had 5 inpatients waiting for heart transplants. And so these patients live at Mayo Clinic with IVs or pumps in them in order to keep them alive to transplant. We had 1 outpatient that received a heart kidney transplant last week, actually. She's doing quite well. And we've had, of the 5 inpatients, 3 have been transplanted. One was a 19-year-old female who was actually on ECMO, 56-year-old male with an Impella through the axillary artery, and a 71-year-old male who was on IV medications. And so, you know, even from January to just a few days ago, we've performed a total of 17 heart transplants, and year over year, we've performed close to 45. And so I think, you know, it's important to understand the donor population and the recipient population. And I think that it's important to kind of correlate the testing that you receive to the organs that are being offered, because a lot of times people will kind of jump to the conclusion that, oh, if somebody had respiratory failure as a cause of death, that was definitely from COVID, given kind of the situation we're in. And I think being diligent and looking at kind of what Dr. Patel explained as far as the potential other etiologies and possible causes for demise may really allow us to take more offers than other centers. And I think the other thing that's important is to look at your local milieu of patients with COVID. You know, if we were in the Northeast, I think this talk would be a little bit different, and the likelihood of transmission would be a little bit higher. And so, you know, looking at our patients post-transplant, what have we seen so far? And so none of our patients have tested positive for COVID via PCR thus far. This includes the new patients that were recently transplanted, which they get COVID testing weekly. We've been able to do a lot of video visits for managing patients more than 2 years out from transplantation. And then we're moving to a non-invasive strategy for patients who have made the 1 year mark and need routine CATs and biopsies with W-Demean or LexiScan. And then we've also started working with remote labs, video visits, and then a lot of just phone follow-up in order to make sure that these patients who are higher risk for contracting the disease and showing minimal symptoms are followed closely, either with labs or just verbal or video visits. And of course, just for a little bit of a laugh, Chuck Norris was exposed, and now the virus is in quarantine for 2 weeks. So now we're going to move on with Dr. Landolfo, talking about our practice and overall what we can do to kind of move forward.
So Rohan, just to interject, so I want to be sensitive with people's time, and so we're already at an hour. Did we want me to go through this, or do you want to open it up for questions? I wasn't sure how long we are designed to go here.
Yeah, sure. Patrick, do you want to weigh in on that?
Yeah, please go ahead, Al-Sheikh. I would keep going. I think this is very valuable to us, and we're all interested in hearing what you have to say.
Okay, all right. Well, it's great to be with you. This is going to be a little bit of a contrarian discussion, and let me preface this by I'm a pretty old guy now. This is new technology. I'm wearing pants, and we've not managed specifically COVID patients, but we certainly have felt the effect, like I'm sure all of you have in your practice. And this is a slide that's been presented in many ways and has been seen, I'm sure, by most of you. But I think it really depicts what has gone on as we've faced this pandemic as a medical community and as a cardiovascular community. And really the first phase of this was all about preparedness, and it was a hammer where we essentially went from a cardiovascular practice going 120 miles an hour to zero, with the desired effect to go much beyond mitigation, but to actually slow the spread, but primarily to allow our medical system to catch up with the expected surge. And like you, I turned on the news every day and talked to my friends and colleagues in New York who were truly getting hammered by this. And so we were all very confident and committed to this first phase. What has really resulted, though, is that there's a second phase for which we are less prepared, which is the dance phase. And we all expected this to be kind of a wave where the incidence would drop, our medical system would be well prepared, and we would sort of put this in our rearview mirror. That's really not what we've seen. So next slide. And what we're coming to understand is that there's going to be a lengthy plateau phase where we're going to be dealing with endemic COVID-19 disease for some time. And this isn't going to be a simple reboot of our practices. It seems to me that reboot is really the wrong word. Our medical system hasn't crashed in Florida, and we're not electively resetting with a clean screensaver, asking politely for a login. We're really moving to a plateau phase where this is a different normal. And like all of you, this generates a lot of uncertainty and a lot of angst for all of us in the healthcare field. And there's a lot of things we can't control. And Rohan talked a little bit about testing, but adequate testing, access to testing, developments in testing are things we can't control as a cardiovascular community. As we switch to containment from mitigation, it's certainly beyond my practice to control contact tracing, and really treatment and vaccine development is being done on a much broader scale. But what we can control is access for our cardiac patients, both on an outpatient and inpatient perspective, and we can control how we approach safety from the patient and from our team with perspectives of PPE, social distancing, and the like. Next slide. It's important to recognize, at least in our practice, that Florida is not the Northeast. Certainly, I've had my brain biopsied on a couple of occasions for exposure. I'm super proud of the way we've prepared for a surge that thankfully didn't come at Mayo Clinic, Florida, and in North Central Florida in general. We're very fortunate that we have access to a reasonably high quality drive-through testing. We have sufficient PPE, and we've, like I'm sure many of you and your organizations have developed SWAT teams and developed operating procedures developed to address some of these needs. But when we really look overall at what our exposure has been, it's been relatively small. In fact, in Mayo Clinic, Florida, which is a pretty contained practice and population, we've had only 109 positive cases, again, thankfully, and our inpatient experience was relatively limited, despite the fact that we have had mortalities in inpatients who pose risk to the staff and to the hospital. Our overall prevalence at the Mayo Clinic system is relatively low. That being said, we have largely curtailed almost all cardiovascular outpatient and inpatient care, like I suspect many of you have. Next slide. So the question is, how do we get this started again? And certainly our major societies have issued guiding principles which are based on a tiered approach to patient triage and the likely prevalence and exposure to COVID-19 patients. And they're based on simple premises: protecting the cardiac patient, protecting the team, and protecting the institution and society at large. And I'm not going to talk too much about protecting the institution. So the vast majority of the U.S. population and the U.S. healthcare system is really in this tier 1, which is a relatively small, and again I say this, giving great thanks to our luck and our environment that our exposure is ultimately going to be less than 30% of our population. And so this really then begs the question, how do we decide and how do we prioritize care? And I would argue that we haven't done this relatively well, at least in our own practice here. I think everybody throughout this, even the preparedness phase of this, we took care of all of our emergency inpatients. But as I said, we largely shut down our outpatient practice, which included many symptomatic patients with valvular and coronary disease, most of our aneurysm and tumor patients, and in fact, our structural practice also was very limited. And now we're in the process of trying to recognize that these patients are an important part of the practice, and that we are in fact jeopardizing patient care by denying them therapy. We also consider, as Rohan mentioned, advanced therapies, and patients with congestive heart failure as part of that essential group. Early on, we talked about trying to refer patients for structural and catheter-based therapies versus open therapy. And at least in our heart team discussions, we've decided that this is kind of a flawed strategy, because as many of the cardiovascular practitioners in the audience will recognize, some of the highest risk exposures are those patients in the cath lab, undergoing echoes and doing the standard things that we're all doing every day. So I implore everybody that it's critically important that we take care of the cardiac surgical patient in the context of our exposure to this new COVID environment. Next slide. So what does that mean? Well, we've got to protect our cardiac patients, but above all else, we have to make sure that we are treating patients and encouraging patients who are understandably reluctant to come both to the outpatient and inpatient setting. In fact, I've had patients tell me, I'm not coming anywhere near that place. And I think it's incumbent on us to educate them in terms of the safety of the environment that we're creating. Again, our tendency was to interrupt all needed cardiovascular care, including advanced heart failure therapies, which we now recognize are critically important to serving our population. At Mayo, all planned admissions and all planned interventions, both in the cath lab and in the OR, undergo standard PCR testing for COVID-19 within 48 hours of admission. We don't allow any hospital visitors into the day or inpatient environment. And we're doing this in order to create a relatively safe environment for patients and staff. We now have strict masking policies for all patients and providers with direct patient care with unknown COVID status in the clinic environment. Next slide. So how has this really affected our outpatient practice, and how much PPE should we wear? This really was a confusing part of our practice, but we have now standardized how we approach and how patients are screened in both the outpatient and inpatient environment. Importantly, all patients who are coming for emergency procedures or who have not had their COVID status directly identified and known within 48 hours, all of the staff were treated with strict donning and doffing procedures, which I'm sure many of you are employing in your labs, which include lead, hand hygiene, very specific eyewear, and high-level protection, including N95 or PAPR, 2 gloves, limiting the contact of patients and limiting those patients in the procedure rooms. So all of these patients with unknown COVID status are assumed to be potentially COVID positive, to protect both the patients and the staff taking care of them. Next slide. In terms of protecting our staff, we've talked about how we handle the procedural areas. Again, all patients in the hospital are tested. We have limited egress and ingress, and all staff members are screened at their point of entrance to work. We are all practicing strict social distancing. We're all wearing masks and eyewear for patient contact. And as Rohan alluded to, we're very cognizant in our heart failure practice of our donor selection, and in particular our procurement teams, who we routinely send into kind of hostile, unknown environments. And all of our teams carry with them their own high-level PPE, and all of our donors and recipients are screened prior to acceptance with a team discussion about the risk of a potential donor and the environment for use in transplant. Next slide. But it's important, and I think Rohan alluded to this, that our advanced heart failure practice is open. I think that increasingly we've got to re-energize our broad cardiovascular practice, which we're now doing at Mayo Clinic. One of my concerns is that through patient and unwittingly through our care providers and our colleagues and our partners in practice, that we may be unnecessarily delaying patients' presentation with non-COVID life-threatening illnesses, and that we've got to view cardiovascular care, and in particular advanced heart failure care, which includes VAD and transplant, as an essential service which should not be interrupted and can be provided safely. Well, this is just, I wanted to end with a discussion of what's going on nationally. And certainly, as Rohan presented, plastered over the news is this dramatic reduction in donor population. But again, I think our national news cycle, and rightly so, is dominated by this horrific scene in the Northeast. This is data now from the Southeast region, and you can see that, roughly speaking, there certainly has not been a fall off in the donors and the procurement done to date from January through up to the middle of April in the Southeast region. So donors are being identified and recovered for our population. Next slide. We do know that particularly early in the COVID experience, patients were being delisted, and this is a look at waitlist activity, and a big orange bar and an orange blue bar is a negative, meaning patients were being deactivated for a variety of reasons, some COVID, some not, particularly early in this exposure. And I think all of us were rightly concerned about how we would manage our patients, what our environment would be in the hospital as COVID patients were expected to surge, and as we saw the environment change in the hospital, and what the donor population was going to be. But again, in the Southeast, most of the programs, and certainly ours, did not shut down completely. And you can see the green line are the Southeast waitlist active patients. You can see they're starting to rise and surge. And so as we see that patients needing advanced heart failure therapies and transplantation are being cared for, and I think cared for well, in the Southeast during this time. And this, I think, puts everything in perspective. This is a look at, again, at adult heart transplantation in the Southeast region. And you can see, if anything, the green line is this year, the number of transplants we are performing continues to increase. So we are getting access to donors, we are transplanting patients, and as Rohan mentioned, we're on track so far to do the largest number of transplants, and have done to date this year in the program's history. Next slide. So in conclusion, I would implore us all to remember that advanced heart failure, even in the COVID area, is an essential service. And I think all of us are committed to providing uninterrupted service and help for our patients and your patients in cooperation with you. I think careful implementation of the 3 guiding principles set out certainly by our surgical organizations are consistent with Mayo's core value, which are the needs of the patients come first. I do think more than ever requires a close working relationship with practices like yours, so that we provide the most efficient and timely care and safest care to patients requiring complex management schemes. And I think with that, I'll stop and then open it up to the group for questions.
This is Dr. Al-Sheikh again. Thank you so much to all of you for a wonderful presentation that we all learned from. And I'm gonna look and see if anybody has questions here that's typed. I'm gonna ask a question about the echocardiogram in hospitalized patients with COVID. I see that from slides, the cardiac involvement sometimes can precede or follow the lung or pulmonary involvement. Even after extubation, the patient can still have cardiac involvement with heart failure and cardiogenic shock. I assume we do echoes on every patient who's hospitalized in the intensive care unit? And if so, and if the initial echo is normal function, in the absence of cardiac manifestations, do you check it again before discharge? And have we seen any patients going home and coming back with heart failure that was not apparent earlier during hospitalization?
That's a great question. I'll start off and have my colleagues kind of answer. And so, again, just like you guys, we haven't had a large kind of cohort of patients. We did a lot of preparation. And one of the things we kind of kept in mind is that if we were going to do echo, it would be for point of care with some clinical suspicion. And so initially we relied on hemodynamics and biomarkers to make the decision as to when to echo somebody. So of course, if there's somebody with a clinical reason for undergoing echo, we would obviously do an echo at that point. However, if somebody came in with respiratory issues, et cetera, our original plan was not to echo every single person across the board. What we were going to do was utilize clinical guidance, as well as for instance, if a troponin, which was trended, went up, or if a BNP was mildly up, or if their hemodynamics suggested that we would do an echo at that point. You know, one of the things we wanted to focus on initially with our ICU team was minimizing in and outs of these patient rooms. Obviously, we're better at our infection control now with a lot of training than we were beforehand. But when we developed the plan, our goal was to minimize ins and outs, and as a result, we did not proceed with echo for all or echo for all at the time of discharge. Does anybody else want to add something to that?
Yeah, I can just add something. Again, it's Kevin Landolfo, and I can only speak to this because my wife is head of the echo lab, and they were very concerned. They shut down the TEE evaluation of these patients, and early on, before adequate testing was being done, they had an isolated machine and were doing sort of single echoes upon admission to the ICU, being done by an attending, and with or without the techs being involved. And this was there was a major exposure incident involving one of these patients, and so there was great concern about exposure to even some of these non-invasive tests, which have been shown, as many of you will be aware, to pose great risk to the sonographers as well as the other people in the room.
Thank you very much. We have another question. Any experience with ivabradine in COVID-related myocarditis and heart failure?
Yeah, this is Rohan. I can address that question a little bit. Maybe Juan can chip in too. You know, so it's interesting that you brought that question up. So, you know, one of the things that we think about with cardiogenic shock and looking at patients with inappropriate tachycardia or appropriate tachycardia is the mechanism of action and the potential effect of negative inotropy. And so there's a couple of case series and case studies, I'm sure you can Google them, from Michigan, that in the time of COVID have had experience with patients on ivabradine having a less profound shock. There's a potential for co-transporter mechanisms that may be affecting that process. There's not really a lot of data on that yet. You know, like we've said, we haven't had that many cardiogenic shock patients with COVID at our institution, but reviewing the data shows that it may be protective, but there's no real consensus right now. There was a report in some of the literature that I was reviewing before this talk, talking about the potential for refractory symptoms with withdrawing from ivabradine. And so there's some potential interaction there that we're not sure about.
Thank you
Just
very much.
This is Juan. There has been no experience at Mayo with the ivabradine, but interestingly, hydroxychloroquine has an effect on the funny channels in the sinus node, and some colleagues have been seeing patients with bradycardia on this drug. Again, many patients, especially in New York, everybody's getting hydroxychloroquine, and they're getting doses that are actually higher than the standard one that we use for rheumatological diseases. It's possible that some of these electrical disturbances that we're seeing in patients being reported might be iatrogenic. You know, we're looking at QT, we're making sure that patients have 12 ECGs where someone is really looking into that. Again, that's something that has been mentioned, hydroxychloroquine actually affecting funding channels. So I'm not sure if there's any ivabradine experience out there. I haven't heard anything yet.
All right. If you guys are still willing to stay around for more questions, we'd really appreciate it. Should I go with the next question?
Yeah,
We're all around.
That's wonderful. Wonderful. Another question here from Dr. Vido regarding COVID patients and the increased risk for thromboembolic events and your recommended protocols dealing with it. What anticoagulants you use, any of the new ones with the concerns about that, and do you discharge patients on prophylactic doses, long-term? Basically, if you can address the issue of anticoagulation to decrease the risk of embolic events or thrombosis in patients with COVID.
That's a great question. I'm trying to think about how I want to answer it, to be honest. I think, you know, there's definitely an appreciation of the fact that many of these, not many, but a portion of these patients are having thromboembolic events, and the data as to what we do with them is very sparse. I do think that if you were to have a patient, and this is again anecdotal, no scientific evidence, but in my mind I agree with Tabet that if you were to have a patient who had evidence of essentially a thromboembolic events, I would actually think it would be very reasonable to provide anticoagulation, I would guess for a couple of months until we demonstrate stability in the patient. But there's no data supporting that. This is just kind of the clinical gestalt, given that some of these patients with this kind of cytokine release syndrome, they definitely have kind of a change in their thrombotic milieu that may persist for longer than the hospitalization. And so I think it'd be reasonable to consider that, but I bet you could ask 10 different docs and each would give a different answer. I don't know if anybody else wants to add.
Yeah, so, you know, this is actually something that's really of interest to me. Thanks for asking the question, Brent. So if you look at the guidelines that have come out from the International Society of Hematology and Thrombosis and Hemostasis, they're recommending using low molecular weight heparin in all patients who are considered potential COVID patients or persons of interest. So they suggest at least one dose of therapeutic Lovenox with consideration for PUIs. And then for those patients who have D-dimers that are being trended in the setting of being positive for COVID, the threshold for anticoagulation that most people are suggesting is a D-dimer that maintains above 1,500 in patients who have received that first dose of Lovenox. And also, if you're checking fibrinogen, they're recommending fibrinogens of above 650 to 800. And in those patients, the data comes from both the UK population and the Duke population. And if you look at the outcomes, patients are, based off of the mechanism of action, they're suggesting discharging patients on Lovenox or Xarelto only, and not using any of the other anticoagulants that are orally based because of the concern for pro-inflammatory side effects downstream based off of endothelial damage that's occurring. So in general, if you encounter these patients, Xarelto or Lovenox, depending on the renal function, of course, and then in patients, if there's persons of interest, Lovenox, and then trending the D-dimer and the fibrinogen. And we're going to be sending a PDF with kind of a summarization of these important questions, and I'll include the source for that, so you guys can look that up as well.
Well, thank you so much. Again, this has been great, and we're about to finish this webinar. Just want to thank everybody for being here. Thanks to our panel of great physicians here, and we really are looking forward to future webinars and events, and we'll be happy to continue to have these events in the future. Again, thanks to all, and have a great day.
Thanks. Stay safe, everybody.
Thank you very much for giving us this opportunity. Stay safe.
Thanks, everyone.